Morning again, everyone. This is a somewhat provocative topic. This may be one that isn't altering how you're conducting your business on Monday morning back at work. But I think it's one of developing importance and some developing science around this. I think I particularly chose this for a Saul Shnider meeting because I've always found this audience a little bit more sophisticated, maybe a little bit more open to subjects that are on the cutting edge rather than just looking for some cookbook approaches to what we do. I'm going to talk in 30 minutes very specifically just about postpartum depression. I think a broader scope of this talk would incorporate post-traumatic stress disorder and other psychiatric outcomes, but I'm going to keep this fairly narrow. I'm going to talk a little bit about the background on postpartum depression, or peripartum depression, as some people, because there's a significant amount of it occurs before delivery. Talk about risk factors and etiologies. There has been some provocative work in the last few years published on the relationship between neuraxial analgesia and a reduced risk of developing postpartum depression. And I thought that many of you may have seen that and may be interested in seeing some of the literature around that. There is a lot of work in medicine right now on inflammation, certainly something that didn't exist, I think, when many of you and I were in school. I'm going to talk a little bit about that's contribution to our understanding of postpartum depression or depression in general, and then talk a little bit about where this is going to lead us in our practices. So this has an incidence of generally, I think this is the best number I could come up with, 14.5% incidence at 3 months. You'll generally find it in the low teens, but it really represents, 1 in 6 women out there are developing this, and this is a health burden of 500,000 people in the United States every year. The mechanisms are multifactorial. The social ones, probably many of you in the room who've had kids understand very clearly, the sleep deprivation as well as many other stresses, but the biological ones are real, and that's probably why this has such a high prevalence in the immediate postpartum period, peaking at 8 weeks. And it has a lot to do with steroid manipulation and other active hormonal substances like oxytocin. It is not that well defined, by the way. The adverse effects range from social and family impacting ones to it has been reported that if a mother has postpartum depression or has some period of depression, it clearly affects the development of her children. So something that's an impact that's affecting a generation below. But obviously the things that get most of our attention are the impact on mortality. And not just that, although most of the discussion of infanticide really falls into the category of postpartum psychosis, not depression alone. The tool we use to define or screen for postpartum depression is the Edinburgh Postnatal Depressive Scale. You'll see this referred to in most literature. It is a 10-question screening survey that asks you in the past 7 days, have you been able to, and it has a series of questions, been able to laugh or feel things, and asks you 4 different qualitative answers, which each have a numerical score associated with it. A score of 10 has been used by obstetricians to follow up with patients more closely, but a score of 13 is what's used, which matches a nice sensitivity and specificity for identifying and diagnosing this illness. Why is this important? I think it goes under the radar. You hear at all obstetric anesthesia meetings, there is at least 2-3 talks that are bringing up a list of what is the leading causes of maternal mortality. I think it's important for you to understand that the CDC, which is our most reliable source of maternal mortality, does not include this in its list. Why? It made an active decision not to include accidental or incidental deaths in this list. Felt that this isn't something that we could influence. One could make a reasonable argument, or at least healthcare providers have less influence on trauma and homicide deaths. Homicide, perhaps. Well, I guess that's a whole different subject, but that's the reason these were pulled out. But as this body of literature builds in terms of postpartum depression, That premise is being challenged to some degree. One case report in a case series out of Colorado, the U.S. state of Colorado, had 100 and some maternal deaths over an 8 or 9 year period, recording with a case rate of 4.6 deaths out of 100,000 live births of maternal suicide, leading us to think that if you start to put this into the context of all these other things you look at, this might actually be the leading cause of maternal death. You saw yesterday some of the California data on maternal mortality, generally showing a maternal mortality death rate in the mid to high teens, something that we're struggling with, something we're attempting to tackle. In low-risk patients, perhaps those are single digits out of 100,000. But if you start to look at the Colorado data and a broader mix of data, it looks like somewhere in the 3 to 5 per 100,000 patients are dying from postpartum depression and suicide. If you rearranged Angie Kranga's list from the CDC, this is probably really what it looks like. Leading cause of maternal death overwhelmingly is suicide, followed by trauma. Then you start to get into cardiac morbidities, sepsis, hemorrhage. So we spend a lot of time talking about those and focusing our energy. But don't kid yourself, this is the leading cause of maternal mortality, by far, actually. What are the risk factors? Preceding depression or psychiatric diagnosis, unquestionably. Some social factors, whether the pregnancy was desired or not, the degree of social support people have. Some different aspects of people's personality. This is one I listed called catastrophizing cognitive bias or distortion, the way you look at the world. It influences a little bit of the business that we do. There's a subset of patients that, well, I'll define it a little bit more in the talk, but perceive the world a little differently, perceive pain a little differently. And it might bias some of the data that comes out in this, but is clearly identified as a risk factor for this illness. If you have a bad outcome, in terms of fetal death, et cetera, this puts you at greater risk, unquestionably. There is conflicting evidence about whether mode of delivery influences the prevalence of postpartum depression. And I'll show you some of the data around that. But most of what I want to focus on here is what about the labor pain experience? Because that is something that we have a little bit more control over, and it has been demonstrated to have an association between this illness. So looking back at 4 papers that start to define what this is for us. This is James Eisenach's work, published now almost a decade ago. Really his focus was looking at acute pain experiences and whether they predict chronic pain. I think you recognize that was part of his work and Peter Pan's work, but also tied in some collaborators, including Patrice Lavandome, from Lille, France, who did some work in this about a decade ago. Took patients who had both had vaginal deliveries and cesarean deliveries and looked at their pain at 36 hours and 8 weeks. 8 weeks, again, is the peak period for postpartum depression, coincidentally, but it is something they looked at this. Although their primary question they were looking to answer was, is mode of delivery predict persistent pain and then perhaps be a risk factor for more chronic pain? But they also were looking at and measured postpartum depression. As we all know, pain 36 hours after delivery is going to look different based on whether you've had a surgical or a vaginal delivery, averaging for cesarean deliveries in the gray bars here somewhere in the 4 to 6 range at that time period, whereas it really is in the 2 to 3 range for vaginal deliveries. But this paper by Eisenach refuted, at least in their investigation, of whether mode of delivery affected persistent pain at 8 weeks and then perhaps set people up for chronic pain. They measured, and I wrote in here chronic pain, but I have to be a little bit more careful. That probably is, I would refer to, that's an 8-week measure. That's probably persistent pains, maybe a better approach for it. They measured their postpartum depression in this data set from both North Carolina and New York as being in the low teens. And they did see an association between high acute pain scores and pain scores at the 8-week period and the development of postpartum depression. They had a schema in this paper that said, here are the 4 variables that we're identifying in this. We've eliminated on the far right of that mode of delivery with this, but there is a bidirectional relationship between acute pain and the development of persistent pain and postpartum depression. It's an association, but an unproven cause and effect, I should say. A subsequent larger survey out of Canada looked at 5,000 women, again looking at pain at 3 months, but they were specifically looking at the question of postpartum depression. They looked at pain at 3 months, and then they surveyed women with an Edinburgh postnatal depression scale somewhere later with a range of 5 to 14 months, averaging 7 months afterward. But they identified an increased odds ratio that was significant, identifying pain at 3 months in the development of postpartum depression. Again, is it cause and effect, or is it an association, or is it a causal relationship? Unclear. When you start looking in, then, if pain is going to be identified as a risk factor, then we know that there's a differential pain experience based on how people choose labor analgesia. This is a paper out of Finland that looked as in a prospective way at 185 women who had different forms of labor pain and looked at the question of postpartum depression. Their postpartum depression rate, the more meaningful one, at 4 months. Consistently, you'll see paper after paper about 1 out of 6 women developing this diagnosis. They also identified that there was no, like the Eisenach paper, no relationship between those who had cesarean delivery or vaginal deliveries. But here are the data that was the interesting part of this. This paper was published in one of the lower impact journals, so I don't think a lot of people saw it. But what they pooled people into 3 different groups: no analgesia, those that had epidurals or paracervical blocks, which is not something that we normally pool, but fair enough, this is how they looked at it. And they looked at patients who received nitrous oxide and acupuncture, and then looked at their postpartum depression rate. This is a very small study, but take a look at the numbers there. 11% postpartum depression rate, approaching kind of a normal rate for epidural. But those who chose, importantly say they chose, were not randomized to no analgesia, had a pretty high rate of postpartum depression. Was that an effect of this choice of receiving no analgesia and having higher pain scores, presumably in labor and at delivery? Or are they is there selection bias here? Is this a different patient population? I think many of you have some sense of perhaps where that goes. But this is the paper that got everyone's attention 2-3 years ago, and it was published in Anesthesia and Analgesia, a prospective observational study out of China, 214 women that had received epidural analgesia in labor. They were matched to 107 women who did not receive an epidural. And again, the measurement was postpartum depression, looking at 3 days and then again at 6 weeks, and 6 weeks being the primary outcome. Again, a statistical difference in the development of this problem between these 2 groups. The numbers, interestingly, are pretty consistent with that smaller sample size that came out of Finland. That is that those that received epidural analgesia were in the low teens, approaching a normal prevalence, but those that did not receive epidural analgesia had a several-fold higher incidence of postpartum depression. Digging into the data from this, and I hope you can see that but on the very top is pain scores between the 2 groups. Pain at delivery, 10 in the group that didn't get an epidural, and on average 3 for those that did get an epidural. Pretty consistent with, I think, what is our experience, our own personal experiences with labor, analgesia management. As I mentioned to you, or maybe not, there was a difference in cesarean delivery in this. I'll talk a little bit about that. Again, remember, there's conflicting evidence about whether mode of delivery contributes to chronic, persistent or chronic pain and postpartum depression. But at least it is a difference in this data set. But again, there at the bottom are the numbers on the postpartum depression, including their Edinburgh postnatal depressive scale scores. So factors associated with the development of the diagnosis. The top 3 on this list here reduce the risk of postpartum depression, or I shouldn't say reduced, it implies causation, but then associated with reduced risk. The bottom 4 associated with an increased risk. So those that received epidural, as I mentioned already, the primary outcome they were looking at. Those that received some form of childbirth classes, I'm not really sure what that consisted of in this Chinese cohort, but perhaps gives some insight about either patient selection, a different patient population, or some degree of management of expectations. I'm not entirely sure what that means. We know from yesterday, I think Alex Macario's talk talked about satisfaction and outcomes in this sphere, and that if you have a good outcome, generally you're happy, and if you don't have a good outcome, you're generally unhappy, and all the subtlety about what we do in anesthesia really isn't teased out in a lot of satisfaction scoring. But as I mentioned, pain was clearly different at delivery, we know that, and they did identify cesarean delivery as associated with a higher risk of this. There were several confounding variables in addition to just mode of delivery in their study. There was fairly substantial differential exposure to oxytocin and success with breastfeeding. Does that matter? Maybe, maybe not. I'll go into that a little bit, but I just wanted to point out the differences in this non-randomized trial. And in the end, I think you have to ask for yourself, is a person who chooses an epidural different than a person who does not? Almost certainly they are. Or does the experience and the pain experienced during labor substantially change your risk for the development of this? So some of the problems with pain measurement in general is that we are unable to measure it objectively. These are self-reported scores. So if you have different type of people, particularly those with different cognitive biases, they might actually rate things differently, and we all have frustrations about that in the management of pain with not just in obstetrics, but in many elements of anesthetic practice. Pain scales have a lot of limitations that I think there's been some publication on that in the recent years. It's unidimensional, essentially. It doesn't tie in anxiety, expectations, the time element of pain, which we often refer to, we can use it as an area under the curve in scientific studies. To talk about pain burden, but Pam Engel has developed a questionnaire that you can pick up more of these other dimensions of pain. The problem is it's time consuming. What do we like about pain, a 0 to 10 scale? It's really simple and really easy. I want to delve into a little bit about subsets of patients and their cognitive perceptions. There is a group of patients that is described in the psychiatric literature as having catastrophizing cognitive distortion or bias. Specifically, the way they view pain, which is the topic of this talk specifically, is different in terms of how they anticipate it differently, how much attention they focus on pain, what their emotional experience is, and their response to it is very different than patients who don't fall into this subcategory of patients that we manage. That being said, the impact of it may not be as substantial as you think. This is a case, this is a study looking at patients with this subgroup versus those that don't fall into this subgroup, and talk about how they measured anticipated pain prior to delivery versus what they experienced. And what you'll see is, yes, there is a significant difference, a statistical difference between these two groups, but it doesn't contribute to more than 1 on a pain scale of 0 to 10. So it does seem to change the way it's reporting, but it may not be as significant as we're thinking about. I want to keep that in the back of your head. I'm pivoting at this point in the lecture to talk a little bit about postpartum depression and some of the leading etiologies to what's causing it. By the way, inflammation is a really important topic in medicine right now. You're seeing it being discussed as having potential implications in a broad variety of diagnoses. It is probably something that we talked almost nothing about in our training, other than perhaps in managing acute postoperative inflammation, but chronic inflammation is the subject that I'm talking about here. It has been implicated in the development of coronary artery disease, Alzheimer's disease, the development of type 2 diabetes, cancer, aging, and yes, this diagnosis, depression. What are the mechanisms? It's been described as modulating perhaps the immune system, altering our hormone levels, which contribute to certainly in depressive states, as well as several other, including even genetic modification, have been implicated. What is the specific information related to depression? I'm not talking about postpartum depression here, I'm talking about major depression in a broad category of non-pregnant patients. This was first identified in Alzheimer's patients, specifically those that had worsened depressive symptoms. Alzheimer's disease and worse depressive symptoms were noted to have higher levels of serum cytokines, inflammatory biomarkers. And those patients, another way to have identified the relationship here, patients who have more severe depressive symptoms, those that have committed suicide, attempted suicide, all had elevated levels of cytokines compared to those that were depressed but did not have those severe manifestations. There is patients who are less likely to be responsive to SSRI antidepressants have been noticed to have higher levels of cytokines. What is the mechanism? I teased it out here a little bit here. In the neurology community is addressing this. Some of this inflammation leads to a conversion of a tryptophan to quinolinic acid, which is a neurotoxic agent that ultimately leads to decreased serotonin centrally, which we know is implicated in the development of depression. But I think it's also important to note that depression as a disease is not a single entity. There are many subsets of this, and I'm not entirely sure if postpartum depression, since we think it's influenced a lot more by hormones perhaps than other forms of depression, is exactly the same as this. But there is some, well, I guess to tease into a little bit more about the biomarkers specifically, there has been consistent evidence that serum interleukin-1/6, tumor necrosis factor alpha, CRP and MCP1 have been correlated with the development of depression. There has been some mixed results of serum interleukin-8 and cerebral spinal fluid interleukin-6 and MCP1. Almost certainly this is a phenomenon that's occurring centrally, but almost all of our evidence occurs in serum. Why? It's obvious. It's hard to get CSF, and that is what influenced our study that we conducted and just published in abstract form a month ago at the Society for Maternal-Fetal Medicine. We wanted to know whether there were biomarkers present in the cerebral spinal fluid of patients, pregnant patients coming in for delivery, that might be something that we could be a target for future therapy. We took 135 women who were coming for elective cesarean delivery. Why not laboring patients? Almost certainly women in pain who were receiving analgesia, oxytocin, had probably alterations or all these several co-founders that may influence our interpretation of these results. We really wanted patients who weren't in pain or laboring. We took 990 women who had risk factors for postpartum depression. Why? We needed to power the study so that we were going to be able to identify some differences and match them to 45 healthy controls in a 2-to-1 fashion. We drew their blood, and we took a CSF sample at the time we did a spinal anesthetic for cesarean delivery and ran a battery of bioassays on these. And then ultimately correlated these 8 weeks later with a similar instrument to measure postpartum depression to the Edinburgh scale. What we identified was that there were 2 markers that have significantly higher risk for those that had positive postpartum depression later. This was interleukin-1b that had been shown in several other studies to be a risk factor, as well as interleukin-23. But also note that we did have a subset of patients within this group that were actually taking SSRIs, which could have confounded the results, and we subsequently re-identified whether this would confound the results. Again, these are all in abstract form and not published yet, so we'll have to address that in the manuscript. But it did give some insight as to what were the mechanistic what were the mechanistic benefits of SSRIs in the setting of high-risk patients for postpartum depression, specifically in that there were two serum, there was one serum and one umbilical cord cytokine and interferon that had lower levels in patients taking SSRIs, and that had also been published previously. This is how these things may partially work. So let's talk a little bit about SSRIs and pregnancy. Should you continue an antidepressant when you become pregnant? It's a controversy. Why? Because there has been some published increased risk of cardiac septal defects in those in class of very effective drugs. That being said, this is a difficult subject. Because the recidivism rate, if you stop an antidepressant, and I didn't present that data in a short talk, but it's pretty profound. You go from a recidivism rate of perhaps 10% during certain time intervals to 40 to 50% if you stop your antidepressants. And in addition to that, who knows what the effect of the development of depression and all the modulation of your hormones on a developing neonate. That's completely unknown. But this has been studied a little bit. 3.7% rate of cardiac septal defects in those who take SSRIs versus 3.1% who have not taken them. That has been the evidence that a lot of people use to perhaps stop at this point. But a better study that came out just a year ago out of a Scandinavian population adjusted this risk in sibling controls. And this was a data set of 35,000 women, pregnant women on SSRIs compared to 2 million who did not take SSRIs, and identified that that risk ratio actually crossed parity and blended out when you looked at it in a more sophisticated manner. This is some of the evidence that's been fueling a stronger push to continue your SSRIs during pregnancy, specifically during the first trimester where you may be at increased risk of developing a teratogenesis. But the other part of this is, as I mentioned to you, you know you're going to have recidivism if you don't continue to take these medications, and what are the implications? If you look back in that Colorado state database, it's extraordinary actually, in that of 27 women who were on, let me think about this again, of 27 women who committed suicide in that database, 13 of them had stopped SSRIs immediately prior to their suicide. 4 of them at the recommendation of their physicians, and 9 of them discontinued it by themselves, presumably with some either informed or uninformed concern about the impact on their baby. So it clearly is one of the most important risk-benefit decisions one has to make. There's a couple of the confounders that I want to tie out in the last 3 minutes here. That is the impact of breastfeeding. We all know the very important public health benefits of initiating and maintaining breastfeeding. In fact, when you start to compare it to several other outcomes on neonates, it really stands out as one of the most important ones, particularly in terms of these specific diagnoses. But note that there is a relationship between depression and breastfeeding. That is, women who are depressed are less successful at breastfeeding. It may also be that the inability to breastfeed, which, by the way, influences sustainable oxytocin levels, may actually affect the depression. So it's not entirely clear which is causing which here. We know that it is controversy about our use of labor analgesia and its impact on breastfeeding. For the most part, it looks like there's not a substantial relationship between neuraxial, traditional labor epidural analgesia, with the exception of those that are using very high-dose opioids. So note that breastfeeding impact, the alternative to neuraxial analgesia, which is high doses of systemic opioids, probably does influence this to a great degree. The other bit that I touched on was oxytocin. Again, another complex relationship. Oxytocin is not just a uterotonic neuropeptide, but it's one that has profound antidepressant effects. We know that we use more oxytocin when we use labor analgesia. Why? Well, that's not entirely clear. Is it because patients tolerate, I think most of us refer to it as when someone has an epidural, you're able to crank up the Pitocin. They're able to tolerate it more. We also know that traditional labor epidural analgesia is associated with longer second stages, and there is more oxytocin administration during that period. That being said, that's a period of oxytocin exposure that may or may not be as important as the endogenous oxytocin exposure that goes on for days, weeks, months afterward. And it may have some relationship to breastfeeding and prolongation of breastfeeding. I refer you back to on these two other variables that are influencing perhaps the results of the DING study. There was a 70% incidence of breastfeeding in those that got epidurals in the DING study that showed this reduction in postpartum depression if you got an epidural in this Chinese population versus 50% that didn't. They also showed that 66% of patients got oxytocin who had the epidurals in that group versus 50% that didn't. So where is this going? I'm not entirely sure, but it certainly is provocative. We do need to probably tease out what exactly is leading to this relationship between pain experience and postpartum depression. Is it a cause and effect one? It may or may not be. There is a lot of work that probably needs to be done in terms of inflammatory science and the development of postpartum depression. Specifically, we know labor analgesia, there's conflicting evidence there itself. We know that inflammation related to neuraxial anesthesia has been implicated in the development in epidural fever in a subset of patients. But we also know in other groups that it appears that neuraxial anesthesia and peripheral nerve blocks have some anti-inflammatory effects. I think for the most part, NSAIDs are used pretty prevalently in our practice, so I'm not sure that we can glean much further in terms of anti-inflammation from some of our traditional methods. But perhaps you could see some targeted medications being used that are going to address maybe some of the cytokines that I had identified associated with the development of postpartum depression. And by the way, some of them, a lot of these cytokines don't cross the blood-brain barrier passively. We don't entirely understand that. It's possible that some of these might be drugs that we're injecting as part of anesthetic techniques in the future. And again, I teased out some of the dynamics between oxytocin and breastfeeding. Again, that has to be studied more carefully. The last thing I want to say to you as I'm finishing the talk here is that there is a bundle as part of the National Partnership for Maternal Health related to postpartum depression. I think compared to some of the other ones in terms of hemorrhage, it is a little bit less weighty, I think, in terms of its evidence and some of its specific recommendations, but I just wanted you to be aware of it. So to conclude, the most prevalent serious complication related to childbirth that we see is actually something that's a little bit off of our radar as practicing anesthesia. And I think there's a compelling argument to think in the context, because it's not present in our CDC data, that this is the leading cause of maternal death and one that should require a little bit more focus from the broader health community, but I make an argument for our community. And again, ultimately, this may lead to how we think about some of the way we manage labor pain and the labor experience. And I will leave it at that. Thank you.